asked Dr. Ravi Kumar, another good friend of mine, to talk about creating a personalized fitness program for us doctors, as well as what we suggest to our patients, because there is a heightened awareness in the background of COVID to improve the immunity as well as the health and wellness of an individual. So Dr. Ravi Kumar is a radiologist, my classmate. He did his DMRD at University of Mumbai and DMRE from the College of Physicians Surgeons of Mumbai, and went on to get DNB radiology. And he is one of the few doctors who have a PhD degree in medicine from the Tamil Nadu Dr. MGR Medical University. So his topic is a very interesting topic: early detection of atherosclerosis using non-invasive imaging modalities. I'm sure he'll share his learnings from his research with us. Also numerous fellowship and research articles. So his main area of interest has been hepatobiliary and pancreatic intervention and peripheral vascular disease intervention. He also travels to many hospitals as a consultant and performed training activities. And he is currently the chairman and founder of GTS Center for Wellness, which is a unit of Thambiran Vascular Institute, and focus on developing, focus on wellness aspect. He has more than 30 scientific publications in national and international to his credit, and also author and co-author chapter in books. I'm very happy to introduce and invite Dr. Ravi Kumar to share his thoughts on from illness to wellness, how to develop a personalized fitness program. Welcome, Ravi.
Thank you, Dr. Nirmal, and I would like to first of all thank the IMA for giving me an opportunity to share my whole journey. Because what I thought was, wellness is a very deep concept, and I hope you are able to see my slide. Are you able to share it?
Not yet. I'll share, or you can do it.
I did it. 1 second. Let me do it. Now, 1 second. Yeah, now? Not yet, sir.
Not yet, Ravi.
Yeah.
Yeah, it's coming.
Yeah, I think now it's there, no?
Yeah.
Okay.
Yes. Yes.
So what I thought was, see, wellness is a deep, it's a whole big topic. So I just thought if I can talk to you on the journey, what as a radiologist, because everybody wonders what a radiologist is doing with wellness. So when I can think of wellness, and all you practicing clinicians can think of wellness day to day, because you see more patients than what we do. So I just thought, let me share a little bit of my journey so that it can give a little bit of thought into all of us. So let me go to the next slide. Yeah. So, I mean, as Adiman put it, like he was talking about stroke, and I'm going to talk about cardiometabolic disease, in the sense both encompass the same scenario. It is more of a complicated lifestyle disorder. And I just thought I will start off with cardiometabolic disease, giving a brief idea of what it is. And as you know very well, that cardiometabolic disease is increasing globally. There's no doubt. There's more amount of morbidity, mortality. But one thing is very good is if you can identify the people at risk groups and you start early intervention, then there's a good chance that you can prevent a premature mortality. What all we're trying to do is not mortality per se. We're trying to prevent premature mortality, because now we can see mortality in less than 50 years of people also. So the youngest people who have been reported worldwide, you can see like at the age of 25, 30, they're having myocardial infarction and so on. So with all these developments, we've been seeing all these developments, scorecards, Framingham scorecard, ASCVD, for the past 70 years it has been on. And many of them are practicing on a day-to-day basis in their clinics. But very surprisingly, the more intensive, even today, there is a rapid increase in the incidence of prevalence of metabolic diseases, coronary artery disease, hypertension, excess weight. So why this is happening? This came into my mind a couple of years back before I did my PhD. I said, why this is there a way how we can address this issue? So Then I realized first we need to know what are the pitfalls that are existing in the current approach. There must be some mistake that we're doing, and what is that? So now what happens is we rely more on acute risk management, the diagnostic tools that are available with us, the medicines, the drug development and discovery, which is absolutely important. I do not deny it. But one thing which you need to understand is they will help to reduce or postpone the premature mortality, but they will not be able to prevent the incidence of cardiometabolic disease. So, but when somebody is focusing on prevention, I think we should go one step or two steps further and start treating it like a global disease. We need to have a holistic approach. This came into my mind and I said, let us see how we can start a holistic approach. Is it possible? So then I went back to what was the definition of wellness. So in 1948, believe me, the WHO has already said that it is not merely the absence of disease. It must be a state of complete physical, mental, and social well-being. But whereas now in our day-to-day practice, we are focusing only more on the absence of disease. If the patient comes with the report, we say, okay, it's perfectly fine, some abnormalities, you can go ahead, and then we stop there. But we do not see the complete physical, mental, and social well-being. And again, there was a revised definition of wellness by Hitler in 1984, which says it is an it is an active process. Trust me, it is a day-to-day process, which as a clinician, we need to encourage our patients to do this. And of course, wellness is good health. There are various domains of wellness. And if you just Google the net, there'll be like 6 dimensions, 9 dimensions, 8, 7, 6, and all that. But if you focus on roughly the physical, social, emotional, spiritual, occupational, and intellectual, I think we are very well covered. And this is how we do the wellness programs as such. Why is it difficult to undertake? If it is so simple, then why not? Because now WHO has clearly admitted, saying that wellness is more of a subjective phenomenon. What I might feel, I'm feeling well today, the other person might not feel. So it is more of subjective. So how can you have a subjective notion into the treatment part, because it cannot be universally standardized? Fine, that's okay. Now what we need to do for that? So that was the next question which came up to me. And we said, there is no uniform objective index till now dated. And there is no uniform operational definition of wellness, period. So if we can arrive at an objective index, that's what stimulated me. Then we said, okay, then somewhere we need to start. We can offer a better wellness program for our patients. So then I said, let us go about. So how best can we improve? So having all the modalities what we have, then I said, we need to have better novel invasive screening program. And that led me to do my PhD on early atherosclerosis imaging. And then it gave me a thing to go about for a postdoctoral fellowship to Canada. So then it doesn't stop there. So once you've done it, then you need to develop a fitness and wellness scoring systems. Because what I feel, I'm just by walking every day 1 hour, it doesn't make me fit at all. It doesn't make me well at all. Period. It stops there. Because you can see still so many people walking for say like 6 years, 7 years, still have a big paunch. So that means he's just walking, and there are only some group of the fitness he is, but he doesn't, he's not a totally fit man. A holistic integrated risk assessment and risk prediction model has to be developed. A robust management of the observed risk, because you need to track these people. It is not that they come to your office, you give up a program, and then you say, yes, boss, you can go ahead. We need to follow them up. Why? Because the data. See how people, what sort of people are responding to your whole program. Who's not responding? Why? Reinstate, and that will give you in future, it will be an artificially driven wellness program, and that is what I'm working towards it. So personalized wellness program, so it must be customized. Every person, it is not one solution for all, because every person is unique, and we have to characterize them and give them a unique program for them. That is what we need to do. So in this we said, this is what the GTS wellness program shows. What we address is, there is metabolic disease, there is metabolic risk. And in the assessment part, we need to involve both. That is whether, I mean, in fact, Adiman was talking about the pulse getting hardened. How can you detect it early? Yes, it is possible. So those are the metabolic risks. And what it manifests over a period of time becomes a metabolic disease. So once I understood this, then I said, I created a program in my clinic And this has been functioning for the past 10 years. So the patient walks in, we get the history. History is like detailed SF36 questionnaire, which is there, which is WHO-based questionnaire, and a little bit more modified, and we also modified a little bit on that. We measure the height and weight, we measure the body mass index, the waist circumference as a measure of abdominal obesity, and we do other things also. We can calculate the visceral fat volume using ultrasound and all those using imaging modalities. We calculate the waist to hip ratio as a measure of abdominal adiposity, bioimpedance analysis. Though many people will say DEXA is the best, but DEXA is cost effective. If I want to start on my clinic, I cannot send every patient to get a DEXA scan. But what is the closest, next closest? Bioimpedance. There are very good bioimpedance analysis which can give you like whatever parameter, intracellular water, extracellular water. You can have so many other parameters, extracellular mass, muscle-free mass. Lot of things can be done. Blood pressure in both upper limbs, supine and sitting, I take, and then we do a clinical biochemistry of the patients for wellness. We do imaging. I got my own ultrasound because in the radiologist, I do my ultrasound. And the vascular health check becomes very important because we need to know how the vascular system of the particular patient is. So we have a functional and we got a structure. I'll just explain to you in the next couple of slides what is functional, what is structural. And we give you a cardiovascular risk questionnaire. We've got a detailed diet questionnaire, wellness questionnaire scoring system with this. And we, in the fitness assessment model, we do the resting heart rate, the heart rate recovery, then we do the target heart rate and the 6-minute walk test, the muscle strength for upper and lower, the endurance, the flexibility, the agility, every aspect of the particular person is checked. Just by doing a 6-minute walk test, it doesn't mean that the flexibility will be good. So depending on all this, then I design a personalized risk scorecard for them. So just to go a little bit inner into the vascular health. See, as Adiman also correctly pointed out, patients are coming at the late stage. If you see in the time course model, every bit of the process what is shown here is the various process which happens before a blood vessel gets blocked. But fortunately or unfortunately, we are focusing in the last 15 to 20, I mean, whatever the time course is, that we look at only the plaque after it's developed, the block, but we do not concentrate on endothelial function. We do not concentrate on arterial stiffness, remodeling, angiogenesis, because all these are, trust me, is reversible. If one can identify any person at this pre-stage of development of plaque, trust me, it is reversible disease. That is why the importance of identifying it much more early. So how do you do it? So you have measures of measuring endothelial function. You got pulsate velocity. You got arterial stiffness index, which says that your vessels are getting stiff. Because if there's a smoker, and if you're finding it difficult for the to take him away from smoking, you do the simple test and you say, see, your arterial stiffness is more when compared to this, you need to stop smoking. Maybe that could be an additional thing for him to say, let me go ahead and do it. Ankle brachial index, augmentation index, pulse pressure, central blood pressures. We all measure peripheral pressures here. Absolutely fine. In the Alcott study, if you see 30% of the individuals, though their peripheral blood pressures has come down, the central blood pressures are still high. And we can also tailor make. The future is going to be like how the AC inhibitors, who has to take AC inhibitors, who needs calcium blockers. That is how it will come up in future. That is why central blood pressure measurement becomes important. And carotid intima-medial thickness is standardized technique, and I think it should be done for everyone. And if these are abnormal, then a very few percentage of the people will be going in for coronary artery calcium scoring. Vascular health testing, we do something called as vascular age measurement, because if I give you a measurement saying it's 0.9, it doesn't make any sense for a layman. So I need to convert it into a vascular age, because that gives them a goal, because we are only as old as our arteries. What I may be looking like 54 today, my blood vessel could be 70, 80. That's why the incidence of premature heart attacks are happening. And what somebody might be 70 years, 80 years, his vascular health might be like 50, 60. So he is better or me is better. He is always much better. So we need to measure what is the vascular age. And these are the various additional things, how a vascular age can be affected. And what is the importance of vascular age is the vascular changes are divided into functional and structural. Functional changes precede structural changes by at least 5 to 7 years. Trust me, even without any medications, you can reverse this process, and it's reversible. So this is the personalized risk scorecard which we give in a clinic, and this is copyrighted and trademarked. And these are the various, if a clinician sees the whole parameter, he will know what is the risk and what is the AACVD risk scorecard, and this is how the scorecard goes about. And the wellness and fitness scorecard, in fact, we go to the extent of measuring the dosha type. In the Ayurvedic system, we have got Vadam, Kappam, Kaba, and Pitta dosha. We also try to measure the dosha type and mention what is the dosha type. We metabolic syndrome, the metabolic age. We give the wellness score, the fitness score, and based on this entire whole process, we decide what is the percentage of physical wellness, what is the percentage of nutritional, emotional, occupational, social, and try to develop these people or give them a program which is suitable for them so that it becomes customized. So it becomes an outcome-based wellness and fitness program. So these are the various programs that we have: cardiac, diabetic, metabolic disease, ideal body shape, nutrition, yoga. Save Your Legs for Life wellness program is what my intervention for peripheral vascular disease does. And Save Your Uterus, we do uterine fibroid embolizations for patients, and there's no need to remove the uterus for everybody. So the take home message will be, just identifying a risk will not reduce, reverse, or prevent cardiometabolic disease. So GTS Center for Wellness, like the center which we started, has been working towards offering a comprehensive wellness model for the past decade, 1 year, and trying to offer them an end-to-end solution. Though it is a small beginning, but if we all come together and if we have the common platform to do it, I think we can do a much more better work, because the future, how it is going to be like is, there's going to be genetic testing, there's nutrigenomics, there's wearable devices, track devices, each one has a Fitbit. And what the Fitbit information gives, I'm not translating into an effective, because as a clinician I'm sitting here, but the Fitbit is used by the patient. I have no communication with them, and it goes a little waste. So if I have integrate this whole system, and if I'm able to offer it to the patient saying, boss, you're overdoing it, step down, or you're not doing enough, you have to do it. So we are collaborating with technology partners, and we are interested in collaborating more with technology partners to become a more personalized wellness and fitness program. I think with this, I would like to, I can go on and on, but I think I should stop somewhere. Thank you.
Thank you, Ravi. That was a nice talk, and we eagerly look forward to check our own fitness. I'm sure there are a lot of questions from the audience. Adi has gone and answered a few of the questions in the chat box. So we'll open the forum for discussion. If there are any questions, can you raise your hand and you can have a discussion, or put it in the chat box. And it's good to know that even at this stage, the structural changes are reversible. So that is quite heartening for many of us who are already spoiled our health.
Yeah, I mean, some of the structural changes, like, carotid IMT is possible, and an early plaque formation. Early means the 1.5 centimeter thickness of plaque is reversible. That has been proven also. And once it becomes a greater than 80-90% stenosis, I think that's the time when people have to go for some sort of an intervention as such.
I think Dr. Ravi Kumar initially quoted by himself, he got the interest, being a radiologist, he got the interest in the wellness clinics. Probably from the school age itself, he got some clue on that, or during the undergraduate period, which time you started thinking about this sort of bringing on the wellness clinics.
Sir, it was actually like after I did my radiology, I went into intervention radiology. And when I started treating these diabetic foot patients with for peripheral angioplasties, though the wounds started healing, they came back with reocclusions and things. So this gave me a thing like, I'm not doing enough, because I'm offering a treatment, but that was not really happy. So then I said, that was the time when I was working with Dr. Bones, diabetist. So I said, I need to do something more. Then I said, I need to do my PhD. Then only I can understand, because we were reading about endothelial function and the whole process of atherosclerosis in Pathology Robbins or Harrison as a chapter. But now each endothelial function, everything has become, volumes of books have been released. So then I said, I need to do something on that. That is why my PhD, that gave me more insight on what I should be doing. So then I said, Then I started off this clinic as more of a diagnostic setup. But again, patients were not coming back with the corrective action. So every year, there's an annual wellness check program that I do. But then I said, no, I need to go one step further to offer a complete wellness. So every time I've been thinking and reading more and developing it. So it's just sort of interested, more passion rather than,
Very nice, very nice.
There are a few
Very
questions in the chat box. So what is your experience with nutrigenomics?
Okay. See, I mean, to say frankly, nutrigenomics, I've not still ventured into nutrigenomics per se. It is a field which is developing. I'm trying to collaborate with some of the, we've got a nutrition consultant, but nutrigenomics is a special area by say. I need somebody who has got an idea on how we do about it. So, but definitely reading the literature, because I do collect a lot of data on nutrigenomics. I know that's the way it has to be done, but unfortunately, till date, trust me, I've not done anything work on nutrigenomics. And I'm sorry, I will not be able to enlighten you, but maybe a couple of years later, I'll be able to offer you some solution to that.
Thank you. And another question from Dr. Vijayarani, arterial stiffness index and augmentation index. Can you explain these two, sir?
Yeah. See, now what happens is when your blood vessels, like your endothelial function is good, that means your endothelium is secreting nitric oxide. And nitric oxide is the one which is very important for your relaxation and contraction of the vessel. So suppose in case if you're going to take a fatty meal or a smoker is going to smoke now, trust me, for the next 4 hours to 6 hours, the endothelium sleeps. That means the relaxation process is not active. So it is becoming stiff. So it tries to recover after 4 hours, but that is the time when you start taking another meal and then still keep it at a slow hit. So what happens when this goes on and on, you're never allowing the endothelium to regenerate or recover. So that becomes stiff. So nitric oxide secretion becomes more and your vessels become more stiffer. That is the earliest sign of atherosclerosis. So there's a parameter, and augmentation index is nothing but we see the central pressure, how much it is getting augmented. So that is what these two parameters are, which says how your blood vessels are getting stiffer. Is it getting stiffer or no? That's what it means.